Welcome to Medicine. I'm Dr. Othniel Doolittle, here today with Dr. Richter to talk about leadership in healthcare and how he became an ER director and then a regional director of emergency medicine after years of practicing as an ER doc in a variety of settings, and just discuss what that looks like and how maybe you could become a leader as well. Thanks for coming in today.
Yeah, thanks for having me.
Yeah. So we've talked before and we spend a lot of time together. And I just love hearing about how you became a leader, because you were like adamantly a pit doc and you wanted to do that work and you disliked leadership and also didn't see its benefit based on where you were at. And then you became a leader, not just an ER director, but then started coaching other directors and taking on this larger position. What is that pathway like? How did that happen and evolve?
Yeah, I think for most of my medical career, I wanted to be a pit doctor, trench doctor, I call it, which is, being in the trenches, not doing anything leadership really related. I wanted to show up for my shift, do my shift, and then not think about my shift when I got home.
Yeah.
I was put in some various interim roles, assistant directorship here, EMS director here, but they were kind of fill-in roles. Never really enjoyed them, thought that they were maybe thrown on to me, didn't really see the benefit of it. And so never really crossed my mind that I would want to do leadership. I was working at Morrison Community Hospital. Integritas ended up taking over the contract there. And I was approached by Integritas about leadership. And I think there was some maybe back talkings to administration at Morrison about who would potentially be a good medical director at the facility. And I guess my name popped up because Integritas came to me and asked me, to which I was very surprised by, because I thought I was just kind of a under the radar, show up, do my shift, and leave kind of person. And so I wasn't looking for it. It kind of sought me out. I think in retrospect, maybe being present in the emergency department, talking to, the ER manager, or maybe troubleshooting things here and there was enough for them to say, hey, he puts in a little bit more effort. May have been the reasoning for Morrison's pick, I guess.
Yeah. But why did you accept?
Initially, I wasn't going to
Yeah.
at all. To be honest, I remember Dave from Integritas coming to visit me on shift, and in Dave fashion, hey, you want to be a medical director here? We heard some good stuff about you. And I was like, no, I just want to show up. And he kind of laid out to me what it would entail. And I said, no, thank you again. And he just said, well, what are you looking for? And if you were to do it, and I had explained to him, well, I don't want to be a paper pusher. I don't want to hound doctors on metrics. I can't stand all the directors that do that to me in my past careers. And he says, we're not like that. You're going to be growing as a physician. You have time to independently become a better leader. You're allowed to have some grace when it comes to mistakes. You're not going to be under a microscope, but we're going to give you the tools to be a decent leader. And are there any problems that you have here? And, I named a few, and he says, we can help you fix those. And so that bit of information that he gave me was enough to maybe make me think about it for a week. And then I remember walking around the emergency department the rest of my shift. I was on a 48, and I was just like, if I was a leader, I could probably change this. If I was a director, I could probably change that. And so went back to Dave actually and asked him about some of these things. And he said, yeah, he's like, these are what we want in a director, are positive changes. And so it felt like for the very first time, I was actually able to maybe make my voice heard instead of just being a trench doctor and complaining about the things on shift that every other doctor complains about, but then not really getting it done.
So you accepted the job mainly because you felt empowered to actually make changes. How does that then translate to how you run your ER as the director?
Yeah, definitely accepted the job because of, the buy-in from Integritas saying, hey, we're going to support you. We're going to allow you to make changes that are for the good. And so thinking about that, ended up accepting the job. And when I took the directorship role, I had it in my head right away that I was going to be predictable, efficient and level-headed as my three kind of pillars as taking over the job. I didn't want to be some sort of authority figure to the other doctors. I also didn't want to be a punching bag for the other doctors. I wanted to be somebody that can offer solutions, but also empower my physicians that I'm leading to come up with their own solutions. Sometimes stepping back, and allowing a provider to maybe come up with their own solution as a way of leadership. And those were kind of the things that I wanted to focus on initially.
I like how we've had that discussion. Like sometimes we do take on too much work because someone brings a problem. We're like, okay, we'll figure out the solutions. And you've been really good about saying like, yeah, so what are the solutions for that problem? And they're like, well, buy a new hospital, buy a new EMR. And you're like, yeah, besides spending $1 billion,
yeah, exactly.
What are some other solutions?
Yeah.
And are they acceptable to are they too big, like insurmountable? And you just have to be like, well, this is where we live. You can't fix CMS guidelines on sepsis or.
Yeah. I mean, there's definitely some aspects that you're not going to be able to change, right? Or there's going to be some big asks that you're not going to be able to give. But knowing where your providers are coming from, knowing that they have that ask and then giving them a reason as to maybe why you can't do this, but maybe we can troubleshoot it a different way, I think is pretty helpful. And it's more conversational, which creates a good rapport between you and someone that you're leading as well.
Yeah, it builds trust.
Yeah.
And that's really important. And in leadership in general is I like your pillars because you're talking about building that trust, being a predictable leader. And that communication and clarity is just really crucial to being a good leader, something that we would love to see in all of healthcare, leaders like that. So what advice do you have for other docs who are frustrated with their leadership or frustrated with their inability to change a system? How do they set themselves up to be surprise tapped to be a leader?
If something's bugging you, see how you can change it. And if you enjoyed doing that and you got satisfaction from it, you're a natural born leader.
Yeah.
I think that's a good test of the water. If you feel like something's bugging you, but you don't want to change it, it must not bug you that much, or you're not that interested in leadership, but at least find the right people to pass it on to in the meantime. I think it takes a specific person that doesn't just want to, and like I said, I was one of these people where I just wanted to show up to my shift, but I often grumbled about things on my shift where I just decided, hey, I think that I can do, I don't want to say a better job than maybe somebody else, but I can do a good job and do good for the hospital and good for the company, and most importantly, good for the patients.
Yeah.
So if you're thinking of those things and not doing it for any other alternative reasons, I think leadership is a good thing to look into.
Yeah. My first leadership position out of residency was a bunch of the old docs who I saw as like the mentors were like, oh no, Doolittle should do it. I was like, why? And they were like, well, you went through and you cleaned up all the paperwork. You cleaned out our refrigerator. You fixed our call room up. And I was like, well, they just things that I could do and things I could fix and problems I saw that I just required someone to go and do something. They were like, well, you enjoy going to meetings. And I was like, I'm just happy to do it for you because you clearly don't want to go to the meeting.
Yeah.
And it's not that hard to sit in a meeting and take some notes.
Yeah, I agree. I think maybe taking a little bit of ownership outside of your job requirements is a good thing. You know, everyone's always trying to skate out of work, I guess. But putting in the extra effort actually gives you a little bit more happiness, I feel.
Well, when your overall passion is what's better for the patients and making systems better for people, then that focus just bleeds out. And like you enjoy doing this because you're helping other doctors, you're helping make systems better for patients. When it's about the money, you see the metrics get pushed, you see docs get burned out and frustrated.
Yeah, and that's my traditional lens was, you know, as soon as I had a colleague turn into a director or an assistant director, they no longer felt like a colleague to me. They very much so felt like somebody that was watching over me and constantly sending me information that I felt wasn't really that helpful for a patient.
Right.
So I really took that patient first approach, which I know is kind of a cliche thing to say in our industry, but really just saying, hey, if we're going to change this, is this going to be good for the patient? And if it's good for the patient, then it's going to be good for everything else. And I think we lose sight of that often. That's patient facing, but taking care of like a physician and their needs. I also try to be pretty protective of my physicians in my leadership roles. You'll get some grumblings from admin or complaints from admin or patient complaints that happen here and there. And you have to know which ones are legit, which ones aren't, and to not bombard and burn out your physicians, like you said, with millions and millions of complaints, because that's not going to be a happy physician group either.
We're already on the edge of burnout.
Yeah.
We're frustrated by the dumb complaints and being that buffer just to make their lives better.
Yeah.
I love that.
And I had thought when I first was going to take over the leadership role at Morrison Community Hospital specifically, I thought maybe I was going to be a little bit more burned out, just taking on more work. And I ended up finding out that my career felt more fulfilling, actually, even though, technically more work. But I'd say within 6 months of taking over that leadership role there, I was able to really streamline 2 to 3 big things in the hospital system that made working there more pleasurable. So then it actually felt like less work. So there's always that added benefit.
Yeah. Yeah. You made your own pool.
Yeah,
nicer.
exactly. Yeah. For sure.
So you talked a little bit about the things that someone could do before they get into leadership. Do you have any particular books or blogs or podcasts that have helped you?
I follow EM Docs a lot on Facebook. There's a sub-medical director group that I like just to kind of get thoughts and processes. I am definitely a person by experience and just go out and try it, which sometimes I get it wrong. But I think since I was a kid, I've been working for various businesses with my mom. I think that has really just put me more of the tangible leadership kind of feeling instead of I read this book and this is how it should be done. I think it's just been through experience. So my recommendation is, I don't have many books that I can think of off the top of my head. It's more get out there and try something. And I was my captain of my basketball team. That's a whole different realm of testosterone in a locker room that you have to control when you're down by a bunch of points, right? For me, it's been more just gaining and grabbing as many experiences as possible, which I feel has kind of shaped my leadership role.
I love it.
Yeah.
We do learn a lot by experience and just going out and finding those experiences too.
For sure.
Like you said, like just see if these things work, see if these solutions work.
Yeah.
It's just a fascinating one, and I've really enjoyed hearing your story. So please tell us more. What happened that led you to become an ER doctor or a doctor in the first place?
I guess if you go back all the way till childhood, I had pretty severe asthma, so was in and out of the hospital a lot. I've been intubated 3 times for respiratory failure. I think the last time was when I was around 12 years old. So just very much so in and out of the hospital system. In a household, in the 90s when everybody smoked, my nanny and my pops, grandma and grandpa, and just constant asthma flares. So I always just remember being in the emergency department as a kid, very, very sick. I remember a particular 4th of July watching fireworks go off at a park district display, and the smoke just really got to me. And being on my mom, like she piggybacked me to the car, basically could not breathe in the car, and ended up like waking up days later. Just very sick all the time as a kid, but was very comfortable in the emergency department. Growing up, I grew up not, a lot of money, single mom, bounced around homes to homes. So the emergency department was also definitely primary care for us a lot of the times. It was shelter for us sometimes when we didn't have housing. Or a way to get some housing. And so, just comfortable in the emergency department because it was there a lot. I started to actually think about healthcare in general, not so much for taking care of patients, although I knew about that. I didn't really understand that that was a job as a kid, but I really, really, really loved science. And so just lots and lots of science, and then realizing, as I got older that, hey, I can take science and I can also help people and do the things that people had done for me when I was a kid. And when I was really sick, definitely sparked my interest. So I remember being a candy striper at a local hospital and pushing patients around, and I thought that was really cool. And then volunteering at certain hospital events, and it just kind of snowballed from there. I think, sometime in middle school, junior high, I said, I think I want to pursue being a doctor. My mom, of course, being a single mom, being like, you will be a doctor. And but we had no clue on how that worked, and really just kind of scudded along most of junior high, even in high school, saying that, but not really having much guidance from guidance counselors or anything. Just kind of figuring it out. I need to take this test or need to do that. I need to keep my grades okay. And just do lots of volunteering. So when I ended up really thinking about it, I started applying to colleges. At the same time, I did apply to the military. I wanted to be a fighter pilot, but they told me I was too tall and too blind. I was wearing glasses at the time. So the recruitment guy didn't sign me up for anything else, which was nice of him. And so I walked out and I said, I guess I will apply to some colleges. Ended up getting into Loyola. And that's where I really felt that I had a strong support system with some new friends that I made that were in the same pre-med track, and Loyola in general, just being a wonderful health science program, really pushed me into wanting to pursue medicine. And then I took a couple turns.
So like a lot of people who spend a lot of time in a hospital would then be scared of it or attribute it to their disease,
right?
Or like, this is where I get shots, or and even just needing to be there for shelter, you're still like dealing with people that are like, seriously, why are you here? And it's not quiet or comfortable, and it's fluorescent lights and it smells weird. Like, but the connection for you was the opposite.
Yeah, I think it was. I think it was because it was a place of comfort in that chaos and smelly fluorescent light setting that you talk about. But I knew that I was there because something was wrong, and I always walked out feeling better.
Yeah.
And so for me, I was like, oh, that's interesting. And, as I pursued, medicine and wanting to kind of do that for other people as I got older, it just felt kind of natural. I had initially, when I was pre-med track, had thought about doing family practice, just always kind of went back to the emergency department mindset. And I think that had to do with my personality a little bit. Like you said, some people maybe don't like the chaos or the weird smells. I was always drawn to it. And I think that's part of my background. I think a lot of my childhood was chaos. And so maybe I just felt comfortable within the chaos.
Yeah.
I don't know.
I've talked to some doctors and very motivated, driven people. And when asked, like, what did you have as your like alternative, or what was your backup plan? Sometimes I'm met with like, what do you mean? Like, I was just going to med school, like all of college. It was just, I'm going to med school. Like that is what will happen at the end of this. Was that the same for you, or did you have any shifts in college?
I mean, my plan was fighter pilot and then maybe med school. So definitely didn't get it that way. But when I was pre-med, I had thought, well, what am I going to do if I'm not this? And as I said, my mom was like, you will be a doctor, the first person in our family to go to college. Things of that nature were always kind of ingrained into me. But I had always thought, well, I'll probably just take over my mom's business or something like that. I know how to run it already. I'm 16 and, I'm managing, her employees while I'm also doing schoolwork and things of that nature. So I was just like, I'll probably end up just doing that. And I actually thought that being a physician wasn't attainable. I didn't think it was something that I was going to actually become. especially after first year, weed out year, inorganic chemistry specifically for me. And so looking back on it now, I think, yeah, I probably would have been in some sort of business role had I not ended up being a physician. Yeah.
Isn't it fascinating, like all the inorganic and organic chemistry that we used during med school?
100%.
Physics and calculus. Yes, all those really important things.
I know, right?
Yes.
Yeah. I often think about biostats in first year med school. And if you're not a researcher, I was just like, this does not need to be a class. Yeah.
Yes. 100%. There's a lot of things that we're missing in med school that
yeah.
really good.
So the social aspect, the care aspect, the burnout aspect, our personal mental health aspect are all things that really need to be brought up into the light and taught maybe a little less inorganic chemistry.
Yes.
Yeah.
Or drugs. It always bothered me first year med school. They're like, memorize all these cardiac drugs. None of them will be out there when you're
done.
Yeah. And it's like, but it's a test. Yeah. And if you don't pass it, you're going to fail out of med school.
That I'd honestly say that was my least favorite part of med school for sure. I loved third and fourth year of med school when you were actually 100%. Out doing rotations, talking to patients, and you felt like you were making a difference.
Yeah.
But memorizing microbiology in first year med school, the worst.
So, yes. Yeah. But we made it. Yeah. What other things should med students be taught? You have a list. I'm always chirping at administrators to teach like administrative medicine.
Yeah.
Because we end up with a lot of healthcare CEOs that are not physicians. And it's because physicians aren't great with finance in general because we're not taught it in med school. Another thing we're missing. And we tend to have this strange entrepreneurial mindset where we can fix everything, but then we don't understand money that well. Mm-hmm. But what other things do you have on your list that should be taught in med school? Or if you have a med student rotating with you, you're like, go study this.
That's not medical related, definitely finances for sure. Yeah. And budgeting, especially when you're in residency, saving early because this is definitely delayed gratification. So when you're in med school, it's 4 years post-college, and then you have 4 years of residency after that. And then you have a mounting debt after all of that. And you had those 8 years where your colleagues that maybe went out of college to do a finance job were putting in money into an IRA and 401 and all of those things, starting that when you're in residency. So financial literacy is huge, something that we lack. Outside of that, I think people skills. I think we really miss people skills. I think there's a lot of smart doctors out there that can, ace an MCAT when they were pre-med and, are top of their class. But maybe lack some of the compassion or some of the people skills that may not translate when they're seeing a patient. They may be the most brilliant on paper, but you have to, I don't want to say win over patients nowadays, but you really have to create trust. You have to create a relationship with the patient, more so in the emergency department than probably any other physician profession. You have 2 to 3 minutes to create an impression with a patient, and you may see them 2 more times, once for a lab recheck to tell them how it's going, and the third one's a discharge, and that's it. So I think it's very important to have that.
It's just a fascinating one, and I've really enjoyed hearing your story. So please tell us more. What happened that led you to become an ER doctor? Or a doctor in the first place?
I'm a DO, and it was one of the reasons that really appealed to me going the DO route was this physician as a whole, and there was a good amount of lecturing and teachings with that, which I really enjoyed. So,
yeah.
Not to say that MDs don't do that, and of course it's combined now and everything, but at the time when I was going into medical school, I just remember it was really, really harped on in my particular school.
Those are crucial. And I think it is fascinating. That's where, as leaders, a lot of times we see physicians fail at a particular hospital. Primarily has to do with their social skills.
Yeah, it's more
communication.
Cultural fit. I think every doctor knows how to doctor for the most part. The really, really poor clinical physicians are usually found out pretty quickly, and they are no longer physicians. So the rest is a cultural, social kind of fit.
Yeah.
And so, yeah.
Do you have any resources that you go to for having to like learning those skills, soft
Um,
skills?
I've had a few mentors, personal mentors, but just putting yourself out there and speaking to as many people as you can and trying to understand people's thought process from their shoes is one of the biggest things you can do. Not making snap judgments, but to listen to somebody that has a differing opinion than you goes a really, really long way to being more open and understanding and being able to talk to a bigger variety of people and have more compassion for somebody, which goes a long way.
Yeah. You've talked before about learning leadership by experience, and you get feedback. You've talked about you trying things as the important thing, because if you fail, you still learn. And it is that growth mindset in communication as well, trying to communicate better and better and paying attention to when the patients are like, that nurse was really nice. It's like, oh, I wonder why. Why do they think that? Like, what did you say to them and what can I do differently? So they say, exactly. That doctor's really nice.
Yeah, I recently had a physician, and a good example of this is a physician that probably gets the most compliments in one of the departments that I lead out of all the others by a long shot. And I asked him recently, I said, we don't get many complaints here. You barely get any complaints here, but you also get just 10 times more compliments than any other physician here. What are you doing? Can I, shadow you, watch you? And, just sat down and listened to him to a patient or two on cross, when we were cross covering. I think the big takeaway that I had from him was just sitting down and just listening and reassuring the patient. And it's something that I thought, maybe I'm not doing that as much as I should or that I think I'm doing. Yeah. And that's a perfect example of just on the job experience and just finding out little tweaks to make your practice a bit better.
So staying a couple hours post shift will save you a ton of time
and patient complaint emails. Yeah, exactly.
Which are just growing in number with everybody being able to look on ChatGPT and to challenge your care.
But it is personality management, right? Yeah. Of course, you're managing a chest pain in room 2 and, a kid with a sore throat in room 3 and whatever it may be. But I often think that it is just people management with just medicine inside of it. Oftentimes, especially now that there's, The Pit on HBO, everyone's like, is this real? Is it, and I have lots of friends text me that aren't in the medical field, but they also ask me, hey, what is it like in the emergency department? I'm like, have you ever been a server before? And, oh yeah, I was a server at Cheesecake Factory. It's like being a server at Cheesecake Factory. This person needs their bill, that person needs their food, they need a refill on their Pepsi. And so you're triaging everything, who's most important, who's the angry customer, who's going to leave you a nice tip, i.e. patient compliment. It is the same thing, except for we're also dealing with lives. But it really is people management. So any way that you can make yourself more palatable, more approachable, more compassionate towards a patient, I think goes a really long way. And full circle back to, I think that's one of the things that really needs to be taught more in medicine.
I do think we have to have that mindset that we're not perfect. And in a leader, seeing that you say, oh, maybe that is something I need to do different. Mm-hmm. You're not even saying this is 100%, but you're also not counting it out. You're not saying there's no way I'm doing this. But asking for that feedback, digging into it and questioning yourself helps you become better. And then it's better for patients.
I'll quote my grandpa, if you're not learning, you're dying. And that's the thing. So, the minute you think you know it all is the minute you become a terrible whatever you're doing. You become complacent, and complacency leads to negative outcomes, I think. Yeah. So, yeah.
How do you do all your work and then also spend a lot of time at home?
Buckets, I think is a good short answer. I will say I'm on shift. So I'm all in on that shift. I focus really, really hard on the shift and make sure that I'm present for patients, for nursing staff, or whoever needs me there. I'm available obviously for calls and things of that nature. But when my wife and my kid know I'm at work, they know I'm at work. So there's a work bucket. When I am at home, I am all present for my family bucket. And, we have dedicated no phone time. to where if, of course I'll look at my phone, but I'll make sure that I'm present for my family. The phone's away. I'm not answering an email that I can maybe answer tomorrow morning. And instead, when my child's glancing at me, I'm not looking at my phone saying, I'm looking at my child, and I think it means all the difference to have eye contact. And same goes with, my partner, my wife. Being able to have a conversation without two tiny screens in your face, working or doing whatever it is, just being present in that moment is very big for me.
Did you changing from more trench stock work to leadership help with that priority of family?
It definitely helped with the priority of family. I was less tired because I was less post-shift, 48-hour shifts and things of that nature. So I was more physically present, and in that realm, I felt more present in my home life, which was great. There was a time where I did feel that some of that transitional work spilled over to where I didn't know when I should stop maybe work at home and say, okay, it's family time now, because I'm so used to clocking in and clocking out that there's not really a clock in and a clock out. You're available or need to be available, or there's always a project or there's always something to do. So you just need to find a different bucket and say, this is my home work bucket. And when I'm finished with that bucket, then I can go and I can enjoy my family. And once I kind of distinguish, like, yes, I'm doing work, but I'm doing it at home, and I have family and I'm doing that stuff at home, being able to separate the two made it a lot easier, I'd say. Yeah.
I really like that, like just breaking things out and not letting it bleed over, even technology bleed over, whether it's just for fun or it's for work.
Yeah.
Really, if it's a priority, you make that the number one priority and don't let anything else in that bucket.
A good example would be health or fitness too. You can say, I'm going to work out, or you can say, I'm going to be a healthy person. And so you either say you're going to do the thing, or you just become the thing that you want to be, right? So I often say, okay, I'm going to put on my ER physician hat today. I'm going to be the physician today. I'm going to be the father, the fun father that's going to play 2 hours before my daughter goes to bed because I'm going to be on a 48-hour shift tomorrow. So instead of saying like, oh yeah, I got to go play with my kid, I'm going to be that active father, and kind of labeling more of the title and owning the title instead of owning the duty, I think really helps.
I really like that analogy.
Yeah.
Well, thank you so much for chatting with me today.
Yeah, thanks for having me.
Thank you for joining us today. If you enjoyed this content, please like and subscribe for some more, and we will be in touch.